Well,
And I
thank you
would
so
like
much.
to introduce my colleague, Dr. Siraj Abu Naja. And حياك الله دكتور سراج. أهلا وسهلا تفضل.
Well, thank you so much, Dr. Abdullah, Dr. Siraj, and GIS and Medtronic. The talk is going to be on the role of renal denervation. It will be focused on patient selection, the evidence behind it, and also the guidelines that actually governing the use of renal denervation, which is interventional procedure. So we'll talk about, why renal denervation. Because the hypertension is highly prevalent and difficult to control despite existing medical therapy. Also, we're going to see how the renal denervation works, the evidence behind it, who is the right patient. So patient selection is very, very important because it's an interventional procedure. Also, the guidelines. Hypertension diagnosis and therapy are failing in many patients, and we know that third of the adult population is actually impacted by hypertension. So 1.13 billion worldwide is affected by hypertension, and other meaning 1 in 4 men and 1 in 5 women actually affected by hypertension worldwide. The 10% of the global healthcare spending is related to hypertension, so it's really costly. And only less than 20% of the hypertensive patients have their blood pressure under control. So the unmet need is actually extensive and a lot, and there's a lot room to go in that arena. So uncontrolled hypertension dramatically increase the risk of MI, heart failure, stroke, and CKD, and that's by evidence. The existing treatments can fail in reaching the hypertension control due to non-adherence. So you see in the complete non-adherence, the dark blue is reaching 20%, maybe sometimes even more, average 17%. So non-adherent to all of the medications. So basically they take it, they stop it, now in 0 medications, and here you go. How about partial adherence? They take 1 or 2 and they leave the rest, approaching 50%. You can see here average 44%. So many patients cannot tolerate polypharmacy and actually they abandon it by themselves. Hypertension is a leading preventive cause of MI, stroke, death, and we can see that by evidence reducing office systolic blood pressure by 10 millimeter mercury only can lead to clinically meaningful reduction in cardiovascular events. So 20% in MACE, 13% in all-cause mortality, 28% in heart failure, and that's reduction, and 27% reduction in stroke, 17% in heart disease in general, or actually ischemic heart disease in particular. So hypertension is considered the third pillar. You start with lifestyle changes, medications, and name them. You can go up to 5, 6, 7 medications, and then renal denervation is the last resort for resistant and uncontrolled hypertension. So how it works, it's actually a minimal invasive interventional approach to achieve the blood pressure reduction. And what it does, we know that actually kidney modulate the sympathetic tone via the renal nerves to control the blood pressure. So renin increase, RAS activation, sodium retention, that leads to decreased renal or kidney blood flow and consequently increase the blood pressure. So what renal denervation actually does, it actually disrupts this cycle. So it disrupts the overactive sympathetic signaling between the kidney and the brain, and then hence it decreases the blood pressure. So you see the renal nerves actually convoluting around the renal arteries, including even the big branches. So denervating that is the idea behind RDN to disrupt this cycle and decrease the sympathetic activation. So again, the available modality is the spiral multi-electrode catheter, where it actually can navigate through tortuosity, and it has 4 electrodes on the helical shape. It's a versatile. It actually fits all eligible anatomy size. So from 3 millimeter to 8 millimeter diameter, it's easy to use. Once you wire the vessels, you can use a workhorse wire. What I do is BMW. You can do any workhorse wire, 0.014, and then you can get the catheter there. Then it will take the shape of the vessel. It will ablate in 4 areas. It's safe, it's automatic, You can see the generators. You can press on the generator. It disabled whatever it see it's not safe. If it's close to a branch, or if it's attaching too much, or if it's not attaching to the vessel wall, it discontinues by itself. So that's what it tells about the safety profile. The evidence, there's a wealthy evidence from spiral hypertension clinical program, 4 sham control randomized control trial, and then real world evidence starting by Global Simplicity Registry, GSR Define. Most of our centers are actually part of that. So that was started from 2017 until now, and included a lot of patients. You can see in the pilot trial, the on medicine, the off medicine, and these are 50 to 120, 180, and 206 patients. But the pooled Simplicity clinical program is over 4,000 patients. So why it's safe? Because it's tested in the GFR, in the GSR defined registry with minimal decline in the eGFR throughout 3 years. It was not statistically significant, nothing really to worry about. And then also it was tested in the 2 meta-analysis, and it showed that no statistical significant reduction in eGFR. And I will show you the reduction in the eGFR. It's actually meaningless. How about safety in the renal artery? No evidence of or procedural adverse events in spiral hypertension randomized controlled trials. And we're talking about a lot of trials that was done to address this one. 0 renal stent implants reported in over 700 Simplicity spiral patients. I've never heard of anything, especially in the GSR Define, that required stenting or even like perf or dissection after ablation. So since there is a little bit of decrease in the eGFR, they mandated eGFR of above 40. So CKD3, but above 40, you can ablate safely. So how about continuous reduction? Is the reduction only in 6 months? Is it in 1 year? Or it can last long? We have data from GSR Define up to 3 years. And you can see here that the reduction actually at 3 years is much more pronounced than reduction at 6 months. And the patient who started with very high baseline systolic blood pressure, they get the most benefit out of it. So the reduction with higher baseline blood pressure has the largest impact on the blood pressure reduction. And again, for patients who have CKD or no CKD, the reduction is exactly the same, maybe better a little bit on non-CKD, but it wasn't statistically significant. It was good in the morning time, the reduction in the morning time, daytime, and all daytime, and nighttime as well, and overall. And we can see here the reduction in the medication is actually there. Maybe it wasn't the intention to measure, but you can see on average of 4.9 to 4.7 on CKD patients, and non-CKD patients from 4.5 to 4.4. So the idea of this therapy is actually helpful, adjunctive, and not to DC the medications. And we can see here the renal or a little bit decline in the eGFR. This is a three years data from GSR Define. In non-CKD patient, you can see they started on average of 87. They end up with 79 eGFR, so not much of a difference. In patients with CKD, also maybe 1 point different, from 44 to 42.8, so not much of a difference. So this is all through the program. Off medicine pilot, on medicine pilot, or on medicine pivotal, which is only 3 months. It showed a reduction of 9.2. On medicine pilot at 6 months, 9.4 millimeter mercury, and at 3 years, actually more pronounced, 20.9. So it lasts longer and actually get better with time. How about GSR Define at 6 months, 13.2 millimeter mercury, and again, a lot of patients there. It's kind of resembling real-world setting. GSR at 3 years, 16.7. And again, it's always on effect on 24-hour blood pressure lowering. You can see it at any time. The high-risk zone, which is the early morning time, late night and early morning time, you can see also its sustainable reduction. So it tells you that it actually limit bias, and also the medication sometimes if you use them, the most effect within the first 12 hours to 16 hours. And even if the medication is for 24 hours, it doesn't last that 24 hours. Again, this is a subgroup, blood pressure reduction in variety of the patient subgroup, resistant hypertension, diabetes. It's kind of consistent reduction in all these groups. AFib, CKD, elderly, prior MI, stroke, all the reduction is there. So we don't have to worry about which patient's gonna respond more than the other. And, you know, this is also another small trial that I found and decided to share with you. Is patient with paroxysmal atrial fibrillation who received renal denervation. This is a small trial, but it was randomized. At the time of randomization, they want to make sure that they're in sinus rhythm randomization. They have LVH or LA dilatation. It tells you that those patients goes in and out of AFib, and more than 3 antihypertensive medications, including diuretics, suspected coronary artery disease. They randomized them to renal denervation versus sham. Sham, you do a procedure, but you don't do the ablation. So basically, it's like diagnostic. Plus ILR, implantable loop recorders to track the patients. So 42 patients on the renal denervation arm versus 38 on the sham arm. And they evaluate the effect of renal artery denervation and blood pressure. They check the office and ambulatory paroxysmal AFib or atrial fibrillation incidence by ILR mainly, and all-cause mortality. And here is the result. In office systolic blood pressure at 6 months, it was statistically significant, and at 6 years, statistically significant as well. But we said the gold standard is ambulatory blood pressure monitor, so 24-hour mean systolic blood pressure is actually reduced also significantly with renal denervation versus sham. How about the incidence of AFib? 62% relative risk reduction in cumulative incidence of atrial fibrillation in this small randomized control trial. And how about mortality? So cardiac mortality and cardiac and all-cause mortality is also reduced. And keep in mind, this is a 6-year follow-up. So yes, it's small size, but you know, it gave us a good information. Meta-analysis, you see a cumulative or an average mean office systolic blood pressure reduction of around 8.5 millimeter mercury at 6 months, and the cumulative of the evidence actually supporting the use of renal artery denervation in patients who have resistant hypertension. A lot of publications and a lot of endorsement in the guideline and consensus documents from 2018 to 2004. I will show you some of them. And in particular, we're talking about European, American, Asian, name it. All the societies basically jumped into that. And where is it fit in terms of the algorithm for resistant hypertension management? So if you have a true resistant hypertension patient, then the first thing is you look at the eGFR. If it's above 30, then you start with first and second line medications, AC inhibitor, ARB, calcium channel blocker, and thiazide or thiazide-like diuretics. If it's not controlled, you add spironolactone preferably, or other mineralocorticoid receptor antagonist. And then if it doesn't work, beta blocker or alpha-1 blocker or centrally acting agents, or you can consider renal artery denervation. So this is where it fits. But the eGFR has to be above 40. So that's an important thing. If the eGFR to begin with is less than 30, the renal denervation is not mentioned in the guideline. So shared decision-making is a key to renal artery denervation. There is so much emphasis on this topic. And it's actually a patient, physician, they sit together, they make a consensus decision on what to do for this particular patient. What factors actually impact those for patients? Blood pressure medication side effects. High blood pressure is seen as a high risk or significant risk by patients. Also personal experiences from high blood pressure, frequent ER visits, headaches, blurry vision, etc. So it's not a good experience for those patients. So they want anything to help. You know, in the over the medical treatments. How about physician recommendation? High blood pressure range. If you check it every time and it's really high, or if you do ambulatory blood pressure and it's sky high despite medical therapy, then maybe you recommend it. You kind of tend to recommend it to your patient. High number of blood pressure medications. They get poured with polypharmacy. So you see patients with 6, 7 medications, then maybe there's more things to offer them. So renal denervation is where it fits. So how about, so shared decision-making is very important after an assessment by multidisciplinary team. So it's not just a cardiologist. Usually the cardiologist's role is actually to do the procedure. But before that, a lot of stakeholders, nephrology, cardiology, family physicians, maybe sometimes even endocrine. Renal artery denervation should be performed in experienced medium to high volume centers. So it's, you shouldn't do it only once or twice a year and be done. So, if you're not going to do it on a regular basis, maybe send it to people who do it on a daily basis, or regularly at least. So in the new 2024 ESC guideline, it's a class 2B recommendation for uncontrolled hypertension patient with increased cardiovascular risk and on fewer than 3 medications. So fewer than 3 medications, but increased cardiovascular risk, and the patient express a preference to undergo renal artery denervation. In resistant hypertension, who have uncontrolled blood pressure on 3 or more drug therapy, including thiazide or thiazide-like diuretics, and always patient preference is there. So it's class 3 as a first line. So never ever tell your patient this is a first line. It's not a first line. It shouldn't replace the medical therapy. It's actually additive to the medical therapy and helpful to the medical therapy. So it's not first line, and it's not to any patients with low eGFR. So any lower than 40 eGFR, maybe you should refrain from that. Also, you need to rule out the secondary etiology before committing patients to such procedure, despite it's been safe. So how about in the European Society of Hypertension? It's a class 2 instead of 3 for uncontrolled hypertension, and same criteria that I mentioned in the last slide, resistant hypertension with eGFR of more than 40. And a class 1 recommendation is actually to do it in a shared decision-making process after a multidisciplinary team decision, and also needs to be done in experienced center to guarantee appropriate selection of eligible patients. And also you want to make sure you complete the renal denervation. So it's not just go in there and do like 3-4 ablations here and there and be done. So patients may ablate 3 to 4 in one, and on the other can be another 3 or 4, or you may end up with like tons of ablations. So I remember one of my patients, I ablated like 38 or 40 in both kidneys. So you need to complete. You need to make sure that you choose every single vessel that it's 3 to 8 millimeter, whether if it's the main or the branches. So bigger branches are very important to ablate as well. And in fact, the nerve actually gets closer to the renal arteries distally, not proximally. So this is just to put all the consensus statements from the various guidelines, European, American, Asian. So the one in red is actually, it looks like they have, they all agree that you need to go for renal denervation. Resistant hypertension with more than or equal to 3 drugs, intolerant to medications, and patient adherence. Those are very important because there is a consistency based or between the inter-society guidelines. Uncontrolled hypertension, non-adherent to medication, and increased cardiovascular disease or risk as well. Universal themes, so you need to make sure that they have uncontrolled blood pressure, elevated cardiovascular risk. Patient voice is very important for patient selection. Also confirm primary hypertension. So rule out secondary etiology. Do the workup before you commit your patients. Make sure it's not a white coat. So how to get to that? Out of the office blood pressure check, whether if it's ambulatory blood pressure monitor, 24 hour or 48 hours, or they do it on their own and they come to you with the log. And also the timing. So don't jump to conclusion and just do it right away. Try to do it in a step fashion. But once you give the patient time, let us say a couple months, 2 to 3 months, and it's not working, then you bring them to do the renal denervation, hoping that you will give them a further reduction on top of the medical therapy. And finally, to put all together,
us
it's for
few
uncontrolled
minutes,
hypertension
Salem,
with EGFR.
Just
Sure.
because of time, we need a few minutes for discussion.
Sure, this is the last slide. So uncontrolled hypertension with EGFR of more than 40 on fewer than 3 medications and increased cardiovascular risk, or in patients with resistant hypertension with EGFR of more than 40 on a 3 or more drug combination, experienced renal denervation centers after multidisciplinary assessment, and also it needs to be done in a shared decision-making process fashion and to take in consideration the patient's preference. Thank you.